Hello, my friends. Ziv Simon here. Welcome to session number 4. So excited to see you in this session. We're going to get started in just a couple of minutes. Our usual routine: check in in the chat box. Tell me your name, where you're from. Tell me about the weather. Is it raining? Is it shiny? And we'll get started in just a couple of minutes. We already have a few people in the room. We'll get going here. Okay, session number 4. And in this session, I'm going to talk about the step-by-step functional crown lengthening. So if you can, let me know that you can, at the moment, hear me loud and clear. I see the first one in the room is Dr. Carl Wirtz from Glendale. So Carl, we have the same weather, a little bit gloomy. Maybe some rain over there. We've got Bill from sunny South Florida. Good for you. Mohammed, Egypt, 3 a.m. Mohammed, you have to go to sleep. Okay, let me just go on camera for a second because I need to tell it to your face. Mohammed, how are you? At 3 a.m. you should be sleeping. Okay, I don't know if you have kids or married or have a wife, but 3 a.m. is really the time to sleep. But I appreciate you being here. Thanks so much. Karen from freezing Nova Scotia. Okay, from Canada. You can hear me loud and clear. My partner, Preeti Mohan here. How are you? I hope our conversation helped you. I hope you cured your scalpelophobia. Okay, Preeti? Nice to meet you. Okay, Mohammed is fine. Good, we're going to get started in just a couple of minutes. This is session number 4. And in this session, I'm going to talk about step-by-step aesthetic crown lengthening. I love this procedure, and you're going to love it as well, because this type of procedure has everything in it. It has the aesthetic component, it has the changing life component, beautiful soft tissue management, bone recontouring. There's a lot to learn and to do with this procedure. And I'll show you 2 cases that I presented last week. And we'll see how their treatment came about. Hi, Angela. I hope all the technical problems are now being resolved. And we're going to get started in just a couple of minutes. In the chat box, you can definitely put in questions during the presentation. Hi, Ludmila from Toronto. It must be cold. And Jason, where are you from? Okay. All right. Yes, Angela, you remember I went to San Francisco. Good memory. It was very nice. A bit cold. Okay, so we are going to get started. Alan from Philly tells me that it's drizzling. You can hear me loud and clear. Fantastic. Okay, we'll get going. Get started. Why not? Everybody's here. Alrighty. Okay, so we'll start. See the first slide, and that you can hear me loud and clear. Hi, Miguel. Jason from Taiwan is here. And lots of people from all over the world. Alrighty. Okay, so in this session, I'm going to talk about step-by-step aesthetic crown lengthening. And I love this procedure. It's my favorite procedure to do. And I hope that you too can start performing it. You'll fall in love with it because the results are immediate. You can see the results almost in an instant. And the healing is great. Very few complications. And you're changing a person's smile, but actually changing their life. So I hope you'll see the results today. So the handout for this presentation is already posted in week number 4. So feel free, after the presentation, log into the online platform. Go to the last post in week 4. The handout is there. And shortly, I'll also post the recording as well, so you can go back and watch it. So I'm going to talk about 2 cases today. One, two of them I presented last week, and I showed you some of the background. I showed you the examination process, the preparation. And basically how I solved the case by examining the patient, evaluating their smile. And I made a point last week to tell you, don't just look at the obvious. Don't just look at what the patient is telling you. Study their smile, but study the patient. Study their motivation, their personality, their background, what they're all about, why they're seeing you, because that's the key, first of all, to provide good treatment, because you'll be able to address the major things that bother them, or you'll know when it's not possible. But you'll also increase your case acceptance. And that's an amazing thing. What a little bit of research, a little bit of discussion, a friendly conversation with the patient, following a certain script, and I showed you the script last week, can do to case acceptance. It's amazing. And I also gave you some resources to read. If you can put in the chat box, did anybody read at least one book or started or bought it at least? I would be so happy to see that. And if you didn't, that's totally fine. You can always do that. Okay? So in this session, I'm going to review these two cases. I'm going to go over the checklist, aesthetic crown lengthening surgery. The checklist is also posted in week number 4, step by step, all the steps that you need to know. We'll go over the steps in this session. And I'm going to start talking about relapse and redos. And when we don't get the results that we want, what are the implications? What happens with that? What is the mindset? How do we deal with patients that are unhappy? And who pays for that? Who pays for the redo? I think it's a very interesting question that is important to discuss. So I'll get the discussion going at the end of this session, but on Thursday, we're going to talk more about complications, dealing with unhappy patients, delivering bad news, and a lot of interesting things that I think you'll enjoy. So as always, I'll send you the link to the next session. Okay, so let's get going with case number 1. I showed you this case last week. This is a patient who is around 50 years old. And his main issue was that he feels his teeth are relatively short and worn. He looks old, and he's really aspiring to get a gig in playing in a Colgate commercial, in a toothpaste commercial. And he got frustrated when he auditioned and he didn't get in. And he saw these beautiful actors, actually actors with beautiful smiles. And that was one of the things that I picked up upon when I discussed it with him. And I also picked up on his special relationship with his grandmother, who used to be a burlesque dancer. All the details are in session number 3. If you can always go back and watch it. And I used these 2 points when I presented the case. And that's so important because the patient said yes immediately. It's so important to custom make your case presentation and hit all the pain points and the emotional points that can help the patient make a decision. Now, some may look at these techniques and think, oh, you're manipulating a person, you're manipulating a patient to make a decision. And this is my opinion. This is my opinion. All I'm doing, I'm marketing and promoting my opinion, what is best for this patient. And it's really your duty to market your recommendation every day of the week. When you tell a patient that they need an implant or they need a filling or they need periodontal treatment, you are voicing your opinion, but you're using all sorts of techniques and you're using all sorts of ways to make your point, and you're marketing. So that's part of marketing. Okay? So if you remember, part of the exam, and part of this process to create a digital simulation and ask the patient a very, very simple question. So what do you think? And pause and let the patient look at the photos. And this is maybe not the greatest. It did work. And the patient signed up for the treatment. So when you're thinking about aesthetic crown lengthening, you are killing 2 birds with 1 stone. You're increasing tooth length, tooth size at the expense of the soft tissue, and therefore you're reducing the soft tissue that is visible. Both. Okay. Carol Simpson is saying no audio. You cannot hear my audio. Please let me know if you can hear me loud and clear. I would appreciate that. So I know if I can get going, just so I don't talk to the abyss. Okay? Can you hear me loud and clear? Let me know if you can hear me loud and clear. Good audio here. Mohammed can hear me in Egypt, so I guess we're okay. Carol, you may want to check your the volume on your speakers. Bill can hear me loud and clear. Everybody's okay. Okay, I'm I panicked for a second. I don't want to speak to nobody. Okay, Ron Daco, I'm glad you're here. So when you talk about when you talk to your patients about crown lengthening, you're increasing tooth size at the expense of the soft tissue. Now, in order to do that, you need to have relatively good soft tissues. And this patient obviously has good attached and keratinized gingiva. Now, I always encourage you to be comprehensive and look at radiographs as part of your comprehensive exam. And when we look at this patient's full set of x-rays, you can tell that this patient has an endodontic lesion on a lower left premolar that was treated endodontically, and another lesion on an upper right premolar that was also treated endodontically. So don't start with aesthetic procedures and elective surgeries before the condition of infection. Okay, very, very important to look at that. And this patient is also planned to have 2 sinus lifts and 2 implants. So this is part of the treatment plan. Is planned to have some periodontal. The treatment plan for this patient is the endodontic treatment that was done, scaling and root planing. He had some pockets, some mild bone loss, aesthetic crown lengthening between the premolars, and a provisional on the upper left-hand side, so we can do the sinus lift and implant while he has a fixed restoration. Okay, and I'll show you how the provisional plays a role in this treatment. Okay, and then of course we'll do the implants and the restorative treatment, which consists of combination veneers and crowns, replacing the pre-existing crowns. Now, that's pretty much the sequence that I would choose. I would probably put in a periodontal reevaluation somewhere in between to make sure he doesn't need anything in addition to that. But this patient is not committed to do the implants, not yet. This is not the only option. It's the best option, but he's not committed yet. And I wanted to share with you his response after we finished his crown lengthening procedure. Okay, so it looks like a $50,000 case. Does he have the funds? Well, we'll find out. We'll find out. Good comment. So I'm going to follow for aesthetic crown lengthening, and you have this checklist, same one, posted in week number 4. And of course, this checklist comes after you evaluate the patient and get all the records and have the discussion with the patient, the informed consent process we reviewed in the previous session. And everything that I showed you before, still never jump into surgery before doing all the diagnostics, and do all of them. Okay, don't just pick one diagnostic, pick all of them, because that will increase your accuracy in the procedure. So choose proportion gauge, a digital simulation, a wax up, a mock up, study the models, make your surgical guide, because based on the surgical guide, you will make your bleeding points. And I just wanted to review very briefly the incision outline for an aesthetic crown lengthening. It technically consists of 3 incisions, or 3 moves. The first incision is a gingivectomy incision between the line angles, and this is a type of incision that is usually an internal bevel in terms of the angle, and it resects the excessive tissue. So basically, with the first incision, you're creating a new gingival margin. You're not getting close to the papilla. There's no reflecting of tissue of any sorts. It's purely between the line angles of the teeth, of course, on the buccal alone, based on your diagnostics. I hope this is clear. Incision number 2 is an intrasulcular incision, and you basically can resect the excessive tissue. So you can use an Orban knife or a curette and expose full clinical crowns. Now, if you're dealing with delayed eruption, what you'll be seeing, you'll see the original tooth structure. If you're dealing with compensatory eruption, you'll probably see some root structure. If you're dealing with previously restored teeth, who knows? you never know, because you have no way to tell. So what's important that after the first 2 incisions is that you have to be happy with your free gingival margin. And I would add some local infiltration into the attached tissue, wipe off all the bleeding, even take your gloves off, and have the patient look in the mirror if possible. And it'll be hard for them to smile, obviously, but have them take a look at it. And a lot of them will say, wow, this looks already so much better. And the most amazing cases are the ones with delayed passive eruption, delayed active eruption. It's just amazing to see the patient's face, because you're exposing enamel that was never there visible before. Okay, so incision number 1, incision number 2, incision number 3 is a secondary intrasulcular incision. And this is what becomes a bit tricky, because now you have to involve the papilla. And I'm going to repeat how. Most of you have seen the videos in week number 4, have seen previous presentations. But the idea here is to create another intrasulcular incision based on the new free gingival margin, and now leading to reflect a full thickness flap. Now, the options mentioned to you probably before are 2. One, you can go with a triangular shape, which is my preference, and that's basically a split thickness incision in the papilla, leaving the majority of the papilla intact. More comfortable, and you feel it's more safe and conservative, you can create an incision between the line angles, basically connecting the secondary intrasulcular incision with a straight line. It'll be, again, split thickness, and that would lead to a full thickness flap. So I hope these 3 incisions are very clear. If they're not clear, put in a question in the chat box, okay? So based on the diagnostics, and I'm going back to the patient, we created a surgical guide, and I'll be the first one to tell you it's great, because I don't see that we're lengthening much. And in principle, we should have a summary of all our diagnostic tools and all the information we gathered during the consultation in the workup represented in the surgical guide. Now, sometimes these guides can deform, like this one, or if the diagnostics was not done 100%, then it's a little bit hard to follow. So use it as a guide, but still use your common sense and use logic. And if the guide leads you to do something wrong, then don't do it. Because what we're planning to do based on this guide is to mark with the periodontal probe the most apical first incision. Okay, the gingivectomy incision, what we call the line angle to line angle. Now, if that's not 100% accurate, then it's not going to help us, okay? So what I always keep in mind, and I always communicate with the dentist restoring the case, I always communicate if the incisal edge needs to be lengthened at all as part of the treatment. I always like to look at the wax up if it's available, or a mock-up. And if yes, I then calculate from the ideal incisal edge position, what's the length of the tooth, and based on that, I mark my bleeding point. Okay, and you can see the bleeding points pretty clearly here on the attached gingiva. Now, if you don't have enough attached tissue, and you have minimally attached tissue, and the mucogingival junction starts 1 millimeter or 2 from the margin, then you can't do that. You have to go with an intrasulcular and reposition apically, but that was not the case. Okay. So, pardon me, based on bleeding point, you'll make an incision between the line angles, and it's not going to be a triangle. It's going to be a continuous scalloped incision between the line angles passing through the bleeding point, okay? And once you created your intrasulcular incision, you'll be able to resect this tissue and look at the amount of tooth structure that you expose. Now, just to give you a little bit of a guideline in regards to the order, the most common place I start, and I think you should do it as well, are the central incisors. Figure those as first. And for this patient, we're planning to lengthen the incisal edge. There was no need to create 10.5 millimeters of length, okay, because we're still lengthening the incisal edges. So I kept this in mind. But I start with the with the central incisors, and then match the canines because they should be around the same level. And then I move on to the laterals and then to the premolars if you wanted to have a little sequence. So centrals, canines, laterals, and premolars to get the most continuous and aesthetic gingival line. Okay? And at that point, local anesthesia in the attached tissue, wipe off all the blood, reassess my work, and make sure that this is what I want. And sometimes I need to do some fine-tuning and refinements, okay, until I'm happy. Don't reflect the flap if you're not happy about your incision outline. Why? Because once you reflected the flap, it'll be very difficult for you to go back and recreate this margin. It's much easier to do this when you have the tissue still attached. Now, whenever you have recession and the gingival line is where it's supposed to, don't touch, okay? This is what crown lengthening. This patient had some recession, he had some compensatory eruption, attrition and compensatory eruption, and the tissue did not follow. So I'm not going to resect any tissue on the upper left canine, okay? Just keep this in mind. Now, here we have a little dilemma because we bridge on the upper left-hand side and we're planning an implant in the number 13 position. Now, we can already set the case up in terms of the soft tissue. Of course, we don't want to have any more crown lengthening on number 13 because the ridge is already shrunk and we don't need more crown lengthening. We don't want that. But we would want to do this on the adjacent premolar so you can plan this as part of your procedure, okay? And just make sure that once you do that, you're basically committing the patient to a new bridge. We're going to expose some of these margins, okay? So keep this in mind. And this patient committed to have either a new bridge or an implant, depending on actually some cost. But I think we can probably make it work for him having the implant done and probably the similar cost to a 3-unit bridge. We can probably talk about it a little bit later, okay? So once you're happy with your incision outline, the next step is flap. Now, a lot of these patients with delayed active and passive eruption have very, very tenacious tissue. So don't get frustrated. Don't start rushing, and you'll tear the flap. Take your time. First of all, work on the interproximal area. Reflect the type of flap of your preference. Whether you choose a triangular or line angle to line angle, it's totally fine. The healing is almost the same. But the flap is mostly attached in the papilla, and this is where it tends to tear or perf. So take your time, reflect the flap, make sure that you're underneath periosteum, go back and forth mesiodistally. It's a pretty large flap extending between premolars. It should not be a problem to reflect because the bigger the flap, the larger it extends, the easier it is, but take your time. That can take about maybe 5-10 minutes. Okay, some of this tissue is very, very irregular. And if you're looking at the underlying bone, you can see that it's also very irregular. Okay, now you can see that I'm leaving most of the interproximal tissue intact. Now, if it looks a little bit messed up, it is, because I decided to use a triangular shape. And if you look at the flap right on top, you see that we have the surgical papilla. We have those triangles, the scalloped shape of a flap, which is what we want. I typically go back to the papilla and I reshape it, make it a straight surface if there are any tissue tags, but I pay extreme close attention not to lose the papilla. Okay, so use sharp blades. All you need to do is just remove a couple of tissue tags, and that should not be a problem. And then I look at the bone. You remember from previous webinars, osteosurgery is really about reshaping bone shape and thickness and creating normal relationships between bone, tooth, and soft tissue. And I showed this before, and I'm happy to answer questions. But if you got this one right, you can be really good about osteosurgery. Okay, and I also would look at the thickness of bone, and you can tell that the bone here is very irregular. Different heights, different levels, different thicknesses, goes up and down. This just cries to be adjusted. Okay, and I'm going to show you how we do that. Now, there are sometimes surprises. Okay, and it's not a surprise, for a birthday party. Okay, a good surprise. It's not a great surprise. If you remember, one of these teeth had an endodontic lesion that was treated endodontically. Now, that does not mean that the lesion is going to close up. And I was concerned if there's an active infection in there, and that was done just a few weeks before. What if this active infection infects the flap? So we have pretty good visibility, the periapical area of the premolar. Okay, so what do you think best course of action if you would encounter something like that during the surgery? Now, I don't perform any endo, and I don't do any apical surgeries, but I'm performing an elective procedure, and I'm seeing this, and what do you think I should do? So Miguel is saying, why don't you do an apicectomy, a picoectomy? You see, that's the problem, Miguel. I don't do that, and I wouldn't be the best person to do that. Any thoughts, except for Miguel? What would be the best course of action? Well, some would say, should we graft it? Should we clean it out and put some graft material? That's a great question. But what if there is an active infection and it needs a retrofill? So I really decided to follow Mohammed's advice, and I decided to curette it and clean it out until all the granulation tissue was out. Clean it out, play it safe, not to do anything, and if it needs to be done in the future, I would defer to the endodontist. And it's kind of a tricky thing, because probably if I had some endodontic training, I would probably come up with a better solution. But you wouldn't want to step on anybody's toes, not just from an ego perspective, because I'm not an endodontist. I don't have the experience performing endo. So I think it's a pretty safe bet to curettage the defect and proceed with the surgery. And this is exactly what I did. Okay, so Angela is absolutely right. You won't know, since the root canal was just done a few days ago. But by debriding the lesion, there's really no harm in doing that. Okay, so that was an interesting surprise. So once you assess the bone and you have that this bone level is irregular and the vertical height is abnormal, and the shape and the relationship between bone, tissue, and teeth is abnormal, the easiest place to start is vertical reduction. And my preference is to use the crown lengthening burr. I would use the large one because there's no need to use the small one that is used mostly for interproximal reduction. I would use the large one and start reducing bone in the vertical dimension. I would hold it parallel with the root, not to damage the root surfaces. And the reduction is done in between the line angles only. Okay, don't go into the interproximal. Don't do any festooning. Don't go there yet. We're going to get there. But all you're doing is reducing bone vertically to a level that is 3 millimeters apical to the new gingival margin. So that's basically step number one. Now, Angela's asked again about the lesion. Do you just debride? Do you believe in placing antibiotics? I think it helps. I did not place any antibiotics, but I believe it helps, and I always mix metronidazole with bone grafts, but that's beside the point. So let's go back to the vertical reduction. The reduction is done only between the line angles in a semicircular motion, holding the burr as parallel as you can to the roots of the teeth to make sure that there's no damage here. And if you don't feel comfortable, you can always use a round burr, thin out the bone to a shell thickness, and then use some hand instruments. The problem with that is that you're losing the gauge of the crown lengthening burr, that is 4 millimeters. Okay, so semicircular motions between the line angles for vertical bone reduction, and that is followed by horizontal reduction, and that's what we call festooning. You remember the interproximal, interradicular area is concave, the area around the roots is convex. Therefore, the transition between the concave and the convex is what we're looking for. And festooning, the best burrs that I found work from larger size, medium and large size diamond burrs. And the best way to do that is to, first of all, create your channels in between the roots. And the depth of this channel depends on the initial thickness of bone. If you have a lot of bone, sometimes I bury my whole burr. But if the bone is not as thick, you can bury probably half of the burr. And once you create a channel, in order to create the convex surface, you're basically connecting between the channels ever so slightly. I don't want you to accentuate too much the festooning. Okay, we had some questions from Australia coming in today, and I'll show them to you, but this is very, very ever so slight transition between concave and convex. And a question that I was asked as part of the course was, how far do you extend the osteoplasty apical-coronally? Meaning, do you go all the way to the apex? And the doctor asked me today in the forum, you can look at week number 4, asked me, so what do you do around the apex? And all I told him, don't get to the apex. The festooning is done in the incisal part of the ridge. Okay, let's say the coronal third or the coronal 2/3 or coronal 50%. And just blend it into the apical area. Don't extend it all the way to the apex. There's no need to do that. That's the festooning is the most critical at the coronal part of the ridge. And that's what's going to help the tissue lay flat and heal better and be stable and not relapse. Okay, I hope this point is clear. Now, 95% of my bone reduction is done with rotary instruments, and the rest is done with the and a straight chisel. So my ocean beam, to finalize my osteotomy, mostly the knife edge that is created between the apical part of the bone and the incisal part of the bone. Okay, it needs to be a knife edge, meaning not sharp, but has to be relatively thin. Okay, and that's done with an ocean beam knife. And then I would look at the new bone reduction, and I would irrigate with some saline. And in regards to this defect, I did not graft it. I irrigated it with some saline. I debrided it. I made sure there's no more granulation tissue in there. And perhaps there's a rationale to graft. I didn't. I just did not want to get involved with the restorative treatment. With the endodontic treatment, and made sure that the bone levels are where I want them. Now, Yashesh from Australia asked me, how do you know that you removed enough bone thickness? What thickness do you need to keep remaining? And I didn't really have an answer for that. But if I had to throw out a number, it would probably be between 1 and 2 millimeters, because that's the normal thickness incisors have, and in canines as well, have on the buccal surface. So if we're just restoring the normal thickness of bone that patients have on just normal circumstances, we're fine. Just be careful not to be too aggressive and reach root structure. Okay, now if you're seeing a fenestration or dehiscence that was there before, not your fault, okay? Not to freak out. Okay, so Miguel is asking how to keep the ideal lengthening control during surgery. That's very important. So I assume you mean in the vertical dimension. So you need to constantly gauge where the ideal gingival margin would be. Is it where the CJ is? So you can measure 3 millimeters apical to that. Is it on the root surface? Now you have a surgical guide that can help you make this decision. And you just need to gauge. I mean, the quality inhibitor has basically a measurement of 4 millimeters. So you'll be able to do that, okay? Now, Mohammed is asking, any bone recontouring done around the upper left canine? Yes, a little bit of recontouring done. A little bit of recontouring, but not vertical reduction. If you remember, this tooth had some recession to begin with, but just a little bit of recontouring to match it with the adjacent teeth. Both adjacent teeth had crown lengthening, so we need to blend it in, create the festooning. Okay. And it's always good to kind of go back, remember how these teeth looked like before. Okay, there was some sort of composite on this canine in the lateral and excessive soft tissue. So what we're actually exposing here is enamel that was never visible in the patient's mouth. So this patient has a combination of compensatory eruption, but also delayed eruption. Okay, delayed passive eruption, delayed active eruption. Let's call it delayed eruption, because there's enamel that is just virgin enamel. It was never exposed at the age of 50 something. So Angela is asking, what if the bone level is not the same level on 8 and 9? For instance, what if the bone is 3 millimeters below the CJ on 8 and 4 on 9? So all I would do, and I kind of matched them, not 100% matching, I would still follow the 3. What it means is that the number 9 in your example has an additional millimeter of dehiscence. And you don't need to do anything about that. You don't have to match them. You need to place the vertical height of bone 3 millimeters apical to the free gingival margin. I think I said this 3 times in this presentation, and I'll say it 100 more times. It's not 100% scientific, but it's one of those rules that just works clinically. And I hope you can try it out. Okay? So once you irrigated, you confirm that the bone levels are where you want them to be. The last step of this procedure is suturing. So if you did your vertical bone reduction properly and you did your horizontal festooning, and the tissue can now lay down flat, and I use a very simple suturing technique, either a simple interrupted with a gut suture material, or you can use a vertical mattress technique, and that depends on the size of the papilla. And I'm sure there'll be a lot of questions about that, but keep it simple. When suturing works best when you keep it simple. Simple interrupted, basically you're engaging the surgical papilla, engaging the interproximal tissue, coming back from the palate. You can engage the palate again. We call it take another bite from the palate, come out through the papilla, and tie the knot. Okay? A vertical mattress works pretty similar. It's pretty good for repositioning the papilla in the ideal vertical height. And what you would do then, you actually have one entry point on the buccal going through the palatal and then coming back through the palatal and then coming back through the buccal again. So you have 2 entry and exit points in the flap. And what does it mean? If you have a large enough flap, sure, it works great. But if you have a tiny little papilla, a small little surgical papilla that is not just small, but it's very narrow, technically you can't do that. You shouldn't do that, because just by perforating the flap twice, you can create ischemia, you can create a tear. So I tend to resort to a simple interrupted technique. I hope this was relatively clear, but keep it simple. Keep the suturing very simple. So let me know if you have any questions about the step-by-step of the procedure. So you noted that there are 4 different steps. There's the soft tissue, the full thickness flap, the ostectomy, the vertical bone reduction, and the osteoplasty. Everything is in the handout in the checklist. You'll be able to see that. So what are the post-op instructions for an aesthetic crown lengthening? Very, very simple. Keep it simple. So I tell them not to floss for the full week. Okay, no flossing, because they'll disrupt some suturing. They'll probably have a little bit of bleeding. Patients don't like that. So the simple instructions in terms of oral care is to use a very soft brush and not get close to the soft tissue. Not use an electric brush. They can brush the palatal aspect very carefully, but there's some sutures going through there, so they also have to be careful. I keep it very simple. They're very similar to the instructions we reviewed in session number 2 for functional quantum computing. In terms of the medications, we're looking at ibuprofen as a main pain relief and an anti-inflammatory. And you can go back and you can definitely prescribe the same medications, just the exact same. That you go back to the presentation. And number 2, some sort of a stronger pain pill, although pain is relatively rare, but for the some pain, you want to prescribe, and maybe more of a narcotic medication as a backup. Okay, so Angela says, I'm a bit confused about the bone level on 8 and 9. Won't the gingival level be different when bone is a different level underneath the gingiva? So Angela, you're intuitive, and I hope everybody can read Angela's question. It's a great question. Intuitively, you're right, because if the bone level is different on 2 separate teeth, why wouldn't the gum level be different? So in reality, the vertical bone height is not the only factor that determines bone level. It has to do with thickness, it has to do with tissue consistency, it has to do with suturing, it has to do with the whole procedure. Because if you're opening up a flap and there's one tooth that has a dehiscence, that does not mean that you'll get recession. Okay, and the same goes for when it heals. Okay, the soft tissue is not a robot that is programmed to follow the bone and position itself 3 millimeters from the vertical height. Okay, and the fact is that you have many patients in your practice that have dehiscences on their teeth and have perfect soft tissues, because there's something called the long junctional epithelium, and that reestablishes itself. Number 2, sometimes there's a difference in bone level. There's nothing you can do about that. Okay, I just want to make sure that everybody's clear that intentionally we are distancing the bone height to 3 millimeters from the new gingival margin. Okay, here I said it again. Alrighty? So post-op instructions, pain medications, and it's optional, similar to what we talked about in session number 2. No need to rinse with anything. 2-3 days later, if the patient really must, they can use some saltwater rinses. There's no need to use Peridex, Listerine, anything like that. Keep it simple. Provide the patient with some gauze in case there's some minor bleeding. Absolutely, they can use very rare. And again, all these steps, all these instructions have been described before, are also posted. So I have now in week number 4, and I believe it's in, you'll see it in a second. Here it is. In part 24, I already uploaded the post-op instructions that I use, and I've uploaded the medication instructions. And in the same download section, you'll see the checklist for static quantum things. So I hope you can, if you watch it again, or just go into the online platform and download the instructions. And I hope this is helpful. You can definitely modify that. Now remember, I custom make these instructions. I write with my handwriting and just write exactly how the patient needs to take the medication, and I put down my cell phone number. Okay, remember. Okay, so a week later, you'll be amazed. Healing is really quick, very fast. The brush that I recommend is the TP brush, Tepe brush. Super extra soft for a week or 2. A week later, the patient can start flossing using a rubber tip, because the papilla is the last part of the flap that will heal. Okay, the new gingival margin will heal very quickly. The papilla is going to take a little bit longer, and it's going to take even a slightly bit longer if you use the horizontal pattern for the papilla. I prefer the triangular, but it's going to take some time. Okay. Now the sutures will be at this point already mostly resorbed. I'm going to use gut 5/0 sutures, and I'll post the sutures again in the online platform. And this is where you need to have patience. It's not going to look all that pretty initially. What you'd like to see first is to make sure that you have the two structure exposed like you planned, and that the papillae are starting to heal slowly but surely. Use all these tools. Bring the patient in a week later. Keep instructing them in proper flossing, massaging the papilla, reducing the inflammation. Sometimes it looks a little bit dramatic, like sloughing, but it's not. It's just normal healing in the papilla area, and it's going to tighten up. No doubt about it. The stippling, if the stippling was there before, it'll come back. And most of your patients will have very, very little side effects. Now be aware, if the teeth are vital and you're dealing with compensatory eruption, there'll be some root exposed. So patients will have dentinal hypersensitivity. That's treated conventionally. Okay, so you'll recommend whatever you recommend for the dentinal hypersensitivity. Okay, take your time, and it really comes from nurturing the papilla and keep instructing the patient and monitor the tissue. See when you start to develop it. Okay, don't move in too fast because the sulcus needs to form. So you'd like to see a 1 to 2 millimeter sulcus on the buccal aspect. And when the tissue looks healthy, you can start your restorative phase. Now, if you remember, there was a bridge on the upper left. I already set it up to be at of the canine and the pontic, okay, around the same level. So really the patient is now committed. Now, if you didn't tell the patient that this is what you're going to do, and they call you or show you, hey, why is this recession on my new bridge? That's not a good thing. Okay, so make sure that you discuss all these issues with your patient, and I think you can see that the gingival level is now the same. Now, a big question, and there's a bit of a controversy here, is when to restore. When can we move on to the restorative phase with veneers, crowns, whatever that may be? What's the next step and when? So in the past, we talked about 6 months. We talked about a year. Some doctors waited a year and a half. It's totally not practical to wait that long. I wait 8 weeks. If I see a good healing, good interproximal tissue that healed itself, I see that the sulcus is probable, meaning I can probe it, let's go. So the answer is 8 weeks, and we can move on to the final restorative phase. Okay, now when I say for the final, because we still have to do our implants, we still have to change the restoration on the upper left-hand side, which is probably going to be 3 separate crowns, 1 on an implant. And when I looked at this picture, I was a little bit, not just concerned, just a little bit disappointed that I didn't do enough crown lengthening on the upper premolar, the mesial abutment for the bridge. And I told him, I'll redo it. I'll refine it, and I'll remove a little bit more tissue, and no worries, I'm not going to charge the patient again. I'll fix it. And the dentist is, why are you worried? Don't worry. It looks perfect. Ziv, you worry too much. Okay, it looks great. You already set it up. Not to worry. The patient will either have a new bridge, or ideally will have an implant and 3 separate crowns. But you already set up the soft tissue to match his smile. So all good, all good. So I want you to keep this in mind, and that's going to make you a better surgeon, not just technically, but just having a good planning capability, just having a good grasp on what you're trying to achieve, and building a new gingival margin into your plan. Okay. Now, Mohammed is asking a very good question. Excellent. How did you deal with the flap and suturing around the bridge and the pontic? Well, it's a little bit tricky. You're right. It's a little bit tricky. Now, I did not reflect the whole tissue underneath the pontic. So you have a couple of options. You can create a little vertical at the pontic side. Not that I created that. or you can create a minor split thickness on a pseudo papilla between the two premolars. It's not a real papilla because there's no tooth in there, just to allow you to reflect the flap. But that's excellent, because many times if you don't reflect the tissue, how can you level the bone? Okay, so Mohammed, thanks for bringing this up. So I did not reflect the tissue from underneath the Pontic. All I did was to create a little opening in there, and I actually have to go back to my pictures and just maybe post it later on in the online program. Okay. So this was set up, and we waited 8 weeks for the final restoration. And unfortunately, I cannot show you this patient's smile and show you his eyes, rather. This patient smiles with his eyes. His eyes become so small when he smiles. And I know this is not a perfect the upper left to deal with, but there was a big change. And if you think about where this patient started from, and being frustrated with small little bonded teeth, and having some gingival display and wear on his teeth, and not being able to book a toothpaste commercial, I think he's on his way. He's not there yet. Maybe he can start with mouthwash commercial. Okay, we start with that, but then he could probably work his way up. There's still some wear on the lower teeth. There's still a bridge and some implants to be done, but we're getting somewhere. Okay, so I hope you can see the transformation that you can achieve for your patients. And trust me, this is going to be a very happy day in your patient's life. Okay, it's going to be a beginning of a beautiful friendship between you and this patient, and it's going to be a beautiful day for you as well. We have our work cut out for us. There's more work to be done, some more implants, but that's later. Okay, so I hope this case was pretty clear. Any questions about that? I'm happy to answer some more questions before I move to number 2. Okay, take a little sip here for my drink. You see, every case is totally different. I don't want you to get overwhelmed if you see a lesion or you see some or dehiscence or fenestration, because every case is going to be different. There are going to be some different nuances that you'll have to be treating differently. So I would like you to be prepared and not to be over. All you need to do is remember the basic rules. Remember all your preparation. Remember your checklist, or don't even remember it. Just put it in front of you. You need to be able to remember the principles of creating a new gingival margin. Remember how to adjust bone level in all dimensions, and lay a flap passively and suture it in the right position. And then you can get consistently predictable results. So he did not deal with the bridge as yet. He's saving some money, and this goes back to Angela's question. This is a $50,000 case. Now, when you say 50,000, are you talking US or Canadian or Australian? We have doctors from all over the world, but it is a big case, and I don't know exactly how much this case is going to cost. And I mean, the crowning thing was a relatively small part of it. But he said something very interesting, and he said this was really expensive, and I'm so happy that I did it, and I'm so happy that I did it with you. Okay, so not a compliment to me personally, but I think it's to the method that you're learning now. It's a method of analyzing a patient's smile, not just focusing on numbers and percentages, focusing on the patient's personality, tailoring, custom making a treatment plan and a treatment that is ideal for this patient. Every patient is different, and this patient needed a lot of work, and it was a stretch for him to get the veneers and the crowns redone and the surgery. But he said, I'm so happy that I did that, and I'm so happy that I did it with you, and I'm going to do the implants, and I'm going to do the crowns, and whatever needs to be done. I'm going to find a way to do that. So Ron, not yet, but he will do that. Okay. So there's nothing to correct it from a soft tissue perspective. This was already set up. The soft tissue was already set up, like you saw in the previous slide. So I'm going to move to case number 2. It's a chronic lengthening case, but it's a totally different case. Totally different patient needs, motivation, young patient, concerned with her short teeth, and she's showing too much gum tissue and not happy about the black triangle. Okay, how are we going to fix that? Let's see. And the bulkiness of the papilla. She had some orthodontics. The papilla got squeezed in there. She had a frenectomy, and she blames the frenectomy in having this type of. I don't think so. I see very clearly the scar where the frenectomy was done. I'm pointing to it right now. So we have a couple of things that we need to achieve here. First of all, we see a totally asymmetrical gingival margin, partially because of delayed eruption. Number 2, some recession on the canine. And if you didn't watch last week's session yet, it's posted. You can take a look at it. You can see all the background, how I set up the case, my analysis, the digital simulation, and also the verbiage that I use, the script in terms of selling the case. Okay, so there are a couple of things that we need to address here. I also showed you last week that there was some type of developmental groove, and there was some tissue collapse or inflammation around it. And all that I said was, this is just the anatomy of the tooth as is. We don't need to match the right central incisor completely. I also told you to be comprehensive. Look at the full case. This patient had some other mucogingival problems that need a graft, and actually the 2 grafts for this patient. And same like the previous simulation. Okay, what am I going to say next? Let's see if you know. So what do you think? What do you think? And I pause. Okay, look at the patient. And the patient says, sign me up. Sign me up. Let's see. Let's see if we can deliver a similar result. Okay? Now, I also pointed out last week that I made a mistake in my diagnosis, in my initial planning, and I unfortunately ignored the excessive gingival display on the upper right-hand side. There's some delayed eruption on both premolars, and I really should have, I don't want to say insisted, but I should have included at least a discussion on both of these premolars. I should have done some simulation on them, and you know, I'm very confident this patient would have said yes, would have said yes to have some additional crown lengthening, and also would have paid the additional cost for that. Okay, because it's a separate area. 7 and 8 is separate than 4 and 5, and you may want to include it as one flap, but there's a difference in cost between crown lengthening 2 teeth and crown lengthening a whole segment. Okay, so that was my mistake. So the treatment plan for this patient is an aesthetic crown lengthening on 7 and 8 only, based on the digital simulation, and to do soft tissue grafting and soft tissue grafting on number 11 and the lower central incisors, which we're going to do in the future. Now, it's important to look at radiographs and look at the source of the black triangle. Okay, we now see that there is no peak of bone. So there was probably a diastema ahead of time before orthodontic treatment. And as these teeth are brought together, that does not mean that the papilla can fully form. So the chances of us fixing the black triangle are close to 0 because there's some bone loss. It's not a peak of bone. It's the bone there is more flat. So we have to be even more cautious in these situations, because it's easy to lose the papilla. If you're being too aggressive in the papilla area, then there's no underlying bone structure that can support the procedure. Okay. So how are we going to tackle this? And we're going to talk a little bit about, okay, because we talked about cost last time. I don't want to spend too much time about cost, but I'm happy to answer your questions maybe a little bit later and help you devise a fee for your procedure. And remember, we're not price fixing, okay? Remember from last time. So how are we going to tackle that? So remember the goals. The goals for this patient was to create some gingival symmetry get rid of some of the excessive tissue and make these teeth not as short, and also to debulk the papilla between 8 and 9. Now, I'm not even putting the goal of fixing the black triangle. That's not even a goal, and it's not attainable. So I didn't even put it there. So if we want to tackle that, we need to start with the first step, which is a soft tissue resection, a gingivectomy procedure, a scalloped incision between the line angles, and then an intrasulcular incision resecting the excessive tissue. I think that's pretty simple. But the question is, how are we going to debulk the papilla? Say debulk, meaning how are we going to thin it out? Are we going to thin it out from the outside, meaning externally, or are we going to thin it out from the inside, internally? So here's the trick. Here's the trick, and I want you to consider these things ahead of time, and it's not always that obvious, and I want you to learn from my mistakes. If you think about aesthetic crown lengthening and you're doing the first internal bevel incision, the first gingivectomy procedure, and you're reflecting a full thickness flap, if you just thinned out the papilla externally, what did you do? You perforated the flap. So I totally agree with Angela. At this point, it's better to thin it out internally so you have a flap. So you have a full flap that is intact. Okay, so the first incision is in between the line connecting to the bleeding point, exposing tooth structure. And we don't have to imagine, if you're not 100% happy with the incision, work on it. You see on the central incisor, there's a little ledge of tissue that I need to resect, and I need to use a fresh blade. Take it out, reinfiltrate the attached tissue. Make sure that I like the symmetry between the centrals, and I achieved a pretty good level from what I can see here. Right? At the moment, I didn't debulk the papilla as yet. Now, what is the next part in aesthetic crown lengthening? A full thickness flap. So as part of this flap, as part of this incision outline, I'm going to already thin out the papilla between 8 and 9. So I'm going to make it actually extra thin. The other incisions are just the same. Okay, the triangular pattern in the interproximal, secondary intrasulcular incision on the buccal of those 4 teeth, but in between 8 and 9, I'm going to make it relatively thin, so I can go back with a fresh, brand new from the box, okay? Make sure that you have enough blades for this procedure, and then you can thin it out internally. Now, don't remove the whole papilla, okay? Don't remove the whole thing because you're defeating the purpose. Just thin it out enough so when you suture back, there's going to be less bulk in there, okay? So a fresh number 15 blade is ideal. And then you proceed with the procedure. Now it's a much smaller flap, okay, so you have to be a bit more careful, and it's a much younger patient. This patient is in her 20s, okay, and the younger the patient, the more conservative I am. The younger the patient, the more intact the dentition, the less restorative treatment is planned, which we're not planning any restorative treatment here, the more conservative I am. And why is that? Because I prefer to have a little relapse or be conservative and not remove enough and go back rather than removing too much. So for this patient, I actually did not use the crown lengthening burr. I did not use a burr for vertical reduction. I only used my round diamond burr, thinned out the buccal surface, and did the rest with a straight chisel. It's basically the same instrument. And created 3 millimeters of distance between the new bone level and the new gingival margin. Okay, and I admit I may have been a bit too conservative here, but I prefer to do that. Again, the younger the patient, the more intact the dentition, the less restoration are planned, or no restorations at all. We're only planning to expose pure enamel. The more conservative I recommend you be. Okay? And then the flap needs to lay back flat. Okay, I usually like to use some finger pressure with some gauze before I suture, and continue with simple interrupted sutures. Now this suture was a little bit too long. I trimmed it. Okay, simple interrupted suturing, and the patient looked at it at the end of the surgery. Says, "Doc, didn't you go too high up? Is it too much? Didn't you remove too much on those treated teeth?" And I said, "No, this is exactly what we planned, and we planned to reduce just a little bit, kind of close to the other central incisor with the defect, but not quite." So that was the exact plan. So don't freak out if the patient tells you, "Hey, didn't you do too much?" Okay, because patients don't see properly. Okay, they will not see. Okay, and I actually showed it. You see, they're almost the same height. Okay, so just remember where we started from. Okay, so it's not a major crown lengthening, but it's more of a selective procedure on 2 teeth and debulking the papilla at the same time. Now, this case is still in progress. Here's a picture from the side. You see the papilla have this bulk anymore. And this is about a week later. Okay, so we're definitely not even healed yet, and we still have some swelling, mostly in the papilla areas, mostly between 8 and 9. So I may have to go back and debulk a little bit more, but I would start the papilla nurturing process. Okay, nurture these papillae. Okay, nurture them, keep the teeth clean, teach the patient how to floss, massage, rubber tip. Okay, like babies. Okay, you gotta care for them and teach the patient to care for them. And it looks like I regenerated some of the papilla, right? But don't forget, this is pure swelling. Okay, I did not regenerate. In this case, it's still in progress. I owe you some more pictures as the patient heals in a couple of weeks. So the black triangle is not gone, Mohammed. It's a combination of a swollen papilla and some interdental plaque. And you're right, we need to educate this patient about home care and nurture these papilla and make sure that it's kept clean so this papilla and the surgical site in general can heal properly. Don't forget, this papilla will not regenerate fully. And if it does, then it's a miracle and it will recede after some time. Remember the periapical picture, there's no peak of bone. So what I'm planning to do, and I will keep you in the loop. I'll keep you posted. I'll keep posting on the same page. I'll post the post-op pictures. I'm planning to let it heal. I'm planning to keep nurturing the papilla with all the tools I mentioned to you, with the TP, taper brush, the soft brush, the floss, rubber tip. Keep seeing the patient on a weekly basis. And then, if necessary, the papilla even more. But this time, we can use an external approach. And if that's what you're planning to do, you have 2 options that work extremely well. One being a round diamond burr, so the same burr that we use for surgery for bone recontouring, you can use for gingivoplasty, no problem at all, or you can use a laser. It's really up to you, or electrosurgery, no problem at all. The question is, who is going to pay for that? Do we charge for the redo? What do you think? Should we charge the patient for a secondary procedure to debulk the papilla? Or if let's say the patient had a crown lengthening done and you didn't really achieve the ideal soft tissue level, should we charge for a secondary procedure to fine tune? What do you think? Let me see what everybody's thinking. Okay, so Ron is saying no. Angela is saying no. David says, why don't we restore the defect on the other incisor? I have nothing against it. I think that's actually a very good idea. That's a good idea. So I agree. I would not charge for that, especially since I mentioned to the patient before during the consultation when I got her consent, her permission to do this. I said, if for whatever reason we need to go back and fine tune and redo change, debulk, reshape. That's all included. I guarantee my work. Okay, so the question here is not an ethical question or what's the legal thing to do, or what should we charge. Yes, we should charge for our work, for our time, and for our expertise, but really it's about patient management. And Angela is right, we have to deliver on the promise. Okay, on the promise. And I think it's great patient management to quote them one fee and promise the result. Okay, so in the next session, actually coming up this Thursday, I'm going to start talking about some minor complications, some problems that I'm seeing, how to fix them. I'm going to talk about some relapse and all sorts of things where the issues of redo and who pays for that are going to surface again. But it's really a patient management, a practice management question issue. Okay? Okay, so I'm going to go on camera. I'm going to stop my presentation. Okay. And I'm going to go on camera, and I'd like to answer some of your questions and spend some more time with you. Thank you for all the attention. Okay. Okay. How's everybody doing? I hope you enjoy these two cases. They're kind of simple, but they have some trick to them. They had some simple with a twist, okay? Another twist of the knot. Something unique about these cases, and every case is totally different. So I want you to be prepared for that, okay? Okay, so let's do some questions. Ludmila is asking, what would you restore with? J-Restore or composite? I don't do that, but I think composite is quite adequate for that. Okay. Okay. So David is answering for me. Restore with a highly polishable composite. Alrighty. I think those cases are interesting too. I think those are very interesting cases that we can all learn from, and it's very rare to have a case that is, how should I call it, textbook. It's pure delayed eruption. You just resect the tissue, resect bone, reshape the bone, it heals, boom, it's done. There are some cases like that. Not too many. Most cases have a little twist, something that deviates, some endolesion coming out of nowhere, some bumpy papilla that needs to be debulked, things like that. Okay, so thanks, Mohammed, for the compliment. I don't think these cases are perfect. Okay, I'm sure you had maybe some constructive criticism about the outcome, about the aesthetic results, maybe even the soft tissue margin, and I totally get it. These are not perfect cases, and they're not supposed to be perfect. What's important is that both patients told me that they are extremely, extremely happy. They're happy about the results. They're happy campers. So if the gingival margin between the two laterals is not totally symmetrical and the patient's totally happy, I'm not going to ruin this for them. I'm not going to book them for another procedure and do more, or tell them, you know what, I could have been a little bit better. No. It's a celebratory moment. It's a moment of celebration where your patient is telling you, Doc, you did great. Thank you very much. I paid you for that. I'm happy for what I paid you, and it was well worth it. And I would do it again if I needed to. Okay? This is what I want your patients to tell you. Okay? What happened to the endolesion? Ron, I got paid. I don't care anymore. That's it. I'm done. No, I'm just kidding. We're just monitoring. We're just monitoring the lesion, and if we see an abscess coming back or a fistula, I assume the endodontist will go in and retreat it, and this time in an apical approach. And I would definitely insist on doing this before we go in and do a sinus lift and an implant, because I have bad experience where sinuses got infected because of an infected tooth. Okay, I'm glad you got the joke, Ron. I was not serious. So these are great cases. So really what I want you to experience is performing maybe 5 to 10 functional crowd lengthening procedures, just to get your hands wet, just to get used to using the instruments, making incisions, reflecting flaps, reducing bone in all 3 dimensions, okay? Reshaping tissue, suturing. Get your skills up there, okay? Get better. And then start performing aesthetic procedures. You're gonna love that, okay? Great, any more questions? Okay, let's see how many people are still in the room. Okay, we have quite a few of us here in the room. How is everybody doing with the course? I don't want you to feel stressed if you didn't watch all the videos yet. I don't want you to worry if you didn't read all the handouts, if you didn't listen to the audio. The audio is slowly being shipped to most doctors. And learn at your own pace. You have time. You have time. Don't procrastinate. Okay, don't waste time, but you have time. Life is busy with practice and family and other commitments. This is why we created this course in this format. Learn when you can, okay? You couldn't make it to the webinar, you're still a nice person, okay? Not to worry about that. You can rewatch the webinar. You can still ask the same questions you're asking me on the forum. You can still ask them offline, meaning when the webinar is not live, and I'll still answer. I think a lot of you who ask questions in the online platform, I'm responding. It's very simple for me to do this from my phone or from my computer when I log in. I do this every day. Okay. So Miguel is saying it's very important that the incisor line be uniform to have an aesthetic result. Absolutely. I agree with you. The incisor line should follow the lower lip if possible. Okay. And this is really where everything starts from, even the planning for aesthetic crown lengthening. Now, Mark is asking, how do we take the exam? Okay, in week number 5, I gave you a bonus week. There's another week in there. You get the email if you're not there yet. There are instructions on how to take the exam. Now, Mark, don't stress out. You will never fail. Okay, there's no chance you can fail that because it's a must pass. Okay. Just to be on the safe side, there is a video just before the exam, and I think it's called that 20 something about crown lengthening. 20 facts. 20 facts about crown lengthening. 20 important facts, something like that. Watch this video. Basically, it goes over every question in the exam. So you'll have a link. You'll take the exam, which is basically electronic, and submit it. Make sure you answer all the questions, submit it, and you graduated. Congratulations, okay? And at the end of session number 6, which is coming up next Tuesday morning, this time we're going to have the doctors from out of the country in a different time zone have a more convenient time to watch. After week number 6, we're going to mail you your completion certificate and your C credits. So some doctors wanted a tax receipt, no problem. Whoever wanted that, send us an email to the help desk, to Ashley, and we'll give you a tax receipt. Okay. Alan is asking, are the audio CDs more involved or are they just transcriptions of the videos? No, this is a completely separate program. It's a program on crown lengthening, but in pure audio form, recorded separately. 6 hours. That the whole point was you can listen to it now from a different source through audio alone in your car, in the gym, whatever works for you. But it's material you didn't listen to before. There'll be some repetition. I'm going to talk about incisions. I'm going to talk about aesthetic crown lengthening. I'm going to talk about functional crown lengthening and the difference, and lip repositioning, a lot of other things that are not in the videos. So it's more involved. It's different. Okay, take your time. Okay, doctors, any more questions? I'm here to answer. If not, I got dinner with my kids and my wife. Okay, so I can't express enough how enjoyable this course is for me as your teacher, as your mentor. I gain real pleasure seeing your success. And if you did already some procedures, hey, you made my day. I see doctors posting on the Surgical Mastermind cases that they did or cases they're about to do. We're already working on our 101 and doing some digital simulations and planning cases. That is totally fun. And I hope you're finding this medium helpful to you and convenient and comfortable and easy and getting a lot of CE credits. And there's no lack in that. And mostly start implementing. Start implementing tomorrow, okay? Do this stuff, okay? It's fun. You know, you'll be a little bit fearful. You'll be a little bit nervous. Totally normal. Do it still. Jump into the water. Okay. So Angela just found out that she has to do a crown lengthening on your cousin for free due to an endolesion and resorption. Can you help me with the case? Absolutely. Angela, my pleasure. Okay. Let's do a one-on-one. I'm going to help you. Do me a favor. Post the case, if you can, on the Surgical Mastermind in our Facebook group. Post it and let's take a look at it. Okay? Let's take a look at it and help you with that. Okay? And just remember, resorptive lesions are a little bit tricky. Okay? They're a little bit tricky because you can never anticipate how far the resorption goes into the tooth, and you can never anticipate how circumferential they are. So many times, just be aware that treating external root resorption is not best treated with crown lengthening. Sometimes it's an open flap repair, and that's included in session 6, so you may want to watch that. Okay, but I'm happy to help you post it. The best way to schedule one-on-one is through the link, and I can post it now in the forum. Okay, I'll post it right now, and I'll post the link to session number 5 this Thursday, so you can immediately register. Okay, session number 5 is coming right up. Okay, you know, the session number 5 link is not ready yet. I apologize, but I'll post the one-on-one. I'm sorry, I'll post the one-on-one link in the Surgical Mastermind. We have a lot of doctors that are scheduling that, and we constantly add more times, and it'll be available soon. But Angela, let's start by looking at your cousin's case. Okay, I hope it's going to go well, and it will go well. Okay, I'm going to help you personally with that. He's young, even more so. Okay, my pleasure. Okay, doctors, we're all done. It's a wrap. I'm going to sign off. Thank you again for your attention. It's been great. You guys are awesome. I'll see you on Thursday. All my best. Have a good night. Take care. Bye-bye.